A 4-year-old child presents to the emergency department with fever, cough, and respiratory distress for the past 4 days. On examination, the child is tachypneic, with decreased breath sounds on the right side. A chest X-ray shows a moderate right-sided pleural effusion. Question 1. What is the next best step in evaluating the pleural effusion? A. CT chest with IV contrast. B. Diagnostic ultrasound of the pleural space. C. Empiric fibrinolytic therapy. D. Repeat chest X-ray in 24 hours. Correct answer. B. Diagnostic ultrasound of the pleural space. Explanation. Ultrasound is the most sensitive imaging modality to assess pleural effusion size, presence of septations, and to distinguish empyema from consolidation or abscess. Question 2. The ultrasound shows a complex pleural effusion with septations and no air fluid level. The child has mild respiratory distress. What is the appropriate next management step? A. I4 antibiotics only. B. Chest tube drainage with fibrinolytics. C. VATS. D. Thoracotomy. Correct answer. B. Chest tube drainage with fibrinolytics. Explanation. In a child with moderate effusion and signs of respiratory compromise or empyema, chest tube drainage with fibrinolytics is appropriate. Question 3. Which of the following pleural fluid characteristics is most consistent with empyema? Correct answer. B. pH 7.1, glucose 40 mg/dl, LDH 1000 IU/ml. Explanation. These findings are typical of empyema and reflect the biochemical changes due to bacterial invasion and inflammation. Question 4. Which of the following pathogens is most commonly associated with pediatric empyema? A. Pseudomonas aeruginosa. B. Mycoplasma pneumoniae. C. Streptococcus pneumoniae. D. Candida albicans. Correct answer? C. Streptococcus pneumonia. Explanation. Pneumonia, especially serotypes 1, 3, 14, and 19A, is the most common cause of pediatric empyema. Question 5. Despite chest tube insertion and fibrinolytics, the child remains febrile with persistent effusion. What is the next best step? A. Remove the chest tube. B. Continue IV antibiotics and wait. C. Perform VATS. D. Add another fibrinolytic agent. Correct answer. C. Perform VATS. Explanation. If the effusion persists despite initial intervention, surgical management such as VATS is warranted. Question 6. Which of the following statements about pediatric pleural effusions is true? A. Biochemical analysis of pleural fluid is not recommended in children. B. CT chest is first line for pleural effusion. C. Large bore chest tubes are preferred over pigtails. D. Repeated needle thoracocentesis is superior to drainage. Correct answer. A. Biochemical analysis of pleural fluid is not recommended in children. Explanation. Guidelines do not recommend routine pleural fluid analysis in children. However, certain values, pH, glucose, LDH, may have prognostic significance. Question 7. A child is diagnosed with necrotizing pneumonia. What is the key radiographic finding that suggests this diagnosis? A. Diffuse reticulonodular infiltrates. B. Consolidation with air bronchograms. C. Cavitary lesions with liquefaction and loss of pulmonary architecture. D. Ground glass opacities. Correct answer, C. Cavitary lesions with liquefaction and loss of pulmonary architecture. Explanation. Necrotizing pneumonia is marked by cavitations in consolidated lung areas due to tissue destruction. Question 8. A 6-year-old child with emphysema has no underlying conditions. What is their long-term prognosis likely to be? A. Permanent restrictive lung disease. B. Chronic emphysema with recurrent admissions. C. Complete resolution without sequelae. D. High risk of mortality despite treatment. Correct answer, C. Complete resolution without sequelae. Explanation. Most healthy children recover without long-term effects. Lung growth compensates for temporary pleural thickening.